under discussion this afternoon is data quality improvement strategies. However, we cannot go straight to the strategies without
Mr. Boy, kindly unmute.
Okay. Okay. I hope I can go on now.
Yes, yes, please.
Yeah, I said we have the data quality improvement strategies as the main topic. However, we can't go straight to look at the strategies without looking at some fundamental elements that will gear us towards achieving what we intend to do this afternoon. So, as Ghana Health Service, the goal is to improve the health status of every person living in the country. And we know the strategies to achieve this are outlined in our usual medium-term development plan, 2022 to 2025, which we all know next year we are starting a new plan. The routine health information system of the service is usually designed to provide quality data for monitoring progress towards achieving goals. Now, building the capacity of managers and frontline health workers to improve the data quality use is paramount. Now, the question we all need to ask now is, what is data? It's very clear. We look at what is data, what is information, then what is the difference between data and information, and why do we need high quality data for service delivery? And we look at some few examples. So before I go on, I will just open the floor. Can somebody just contribute to this few icebreaker? Any of them? The moderator, can you mention those whose hands are up?
Yes. So, okay. I can see Mr. Eric Donyina's hand. Mr. Eric, do you want to contribute to the icebreaker?
Any of them, you can just pick any and respond.
Mr. Francis. Yeah.
Boss, sorry, I raised my hand during the discussion time and I've forgotten to.
Oh, okay.
Oh,
Okay.
Sorry.
All right. So Mr. Francis Edu is on the floor.
Yeah, I want to talk about the data and then the information.
Yes, boss.
Data is a raw fact that has not been processed. And when it is processed, then it becomes an information. So, for instance, if we have 1 and 3, it's the data. And then 1 plus 3 is 4, and that is an information. So, an information is just a processed data, whilst data is the raw facts. Thank you.
Thank you very much. Do we still have more hands? Yes, so Mr. Francis spoke about data and information. We also have other questions that have to do with why we need high quality data. Yes, so Sena is also contributing to the definition for data and information. It says data is a raw fact and information is a processed data. Okay.
Because we don't have much time, we can proceed. Yeah, they are right. But let's also know that sometimes your information may be another raw fact for somebody to process to get another information. And usually we say raw fact, but in most places they will add facts and figures. You know, there is some small difference between facts and figures. If I say black, it's a fact. But if I say 22, it's a figure. So it may even be audio, it may be videos, it may be other pictures and the rest. Now, raw and organized facts that need to be processed to make it meaningful, which they were very right. This includes facts, videos, audios, observations, perceptions, which we are supposed to recognize it very well at our settings. Perceptions need to be actually taken care of. Now, we also have information, as they said, they are the process data in a meaningful form, but in our case, it should be used for the intended purpose, that's for the improvement of our client's status. Now, we have some of this as example. We may not go through all of them, but let's just look at some few examples. We have the data, we look at the collection of the facts. Information is just facts into context. We have the raw and organized form in terms of data, but information is organized. Individual and sometimes unrelated. By information, you have mapped out the data to provide a bigger picture. Then on its own, it is meaningless in terms of the data, but for information, when it is analyzed and interpreted, it has some meaningful form that can be used to improve performance. Data does not depend on the information. Meanwhile, information depends on data because it's a process data. Now, the last part, it is not sufficient for decision-making. Data most often is not sufficient. But decision-making, in most cases, for information, you need it for decision-making. Now, there are reasons why we mentioned this. What is data in healthcare? Because our concern now is high-quality data for service delivery. For the health data, any data related to health conditions, reproductive outcomes, causes of health, or quality of the life of the individual or population, we take it as our health data. This includes clinical metrics, along with environmental, socioeconomic, behavioral information pattern or pertinent to the health and wellness. Now, we are also aware that when a healthcare provider have access to a patient updated health data, they provide more efficient, higher quality, safer, and more personalized care or coordination of care for the individual at stake. There are reasons why this one have come in. As we go along the line, we will revisit it if you want to achieve high quality data. What is the current status of high quality data challenges in Ghana Health Service? And usually, I wish I have not shown that slide. Let's ponder over it. What are the current challenges in terms of we having high quality data for informed decision making? Can we brainstorm about this? Moderator, can we get their perspective?
Yes. So what are some of the challenges we face in our facilities when it comes to data quality? So you can put up your hand or you can put in the chat box. Yes, Sheila.
Bad internet connections.
Bad internet connection.
Hello, can I be heard?
Yes. You mentioned bad internet connection.
Okay.
Is that right?
Noted. Next one.
Any
Is it
more?
only internet connection?
Poor information capture. Poor information capture.
Okay.
Poor capture of the data. All right. Any other?
Data not being documented.
Data not being documented. Thank you. Wrong entries or poor data capture from Evans Kwadjo. All right.
Inconsistencies of data.
Inconsistencies in the data. Okay.
Yes, sir.
Untimely submission of data from Mr. Evans again.
So some of the submission can be put under human, what do you call it? Human resource. Let's say quality of human resource handling this data.
Okay. The availability of trained human resource. Very well.
Okay, thank you very much. That is good. And General Secretary, actually, as they were mentioning the issues, I was just jotting them down. And you get to realize that, in fact, majority of all the things they mentioned are HR issues. Before I go to the main slide, when you take the internet out, almost everything are user compliance related issues. When I joined and you were discussing some of the issues, I heard somebody mention LIMS. To be very frank with you, once in a while, I just enter in of my hospitals to see how they are doing, the challenges they face. In fact, from my perspective, LIMS have issues. When we started it, currently, most of the challenges we have in LIMS are not technical. They are not the software-related issues. They are user compliance. I know some people with that. Go and do your, as you go along, go and do your, just go and try to review. Go and sit down, watch how the PAs or the prescribers capture the data in the consulting room. For about 3 or 4 clients, go back to your office and generate the mobility. You see that it will still be blank. The provisional diagnosis side, you will see that it's blank. The testing side, most of them, you see is blank. Meanwhile, they have diagnosed the person have gone to lab, they've run the lab, they've done everything, and when you generate, you don't see anything in the LIMS mobility reports. Just because user compliance issues were not adhered to. So it's good that you are mentioning that most of the issues are HR related. Now, with what I have here, the current data management challenges in Ghana, fragmented data systems across facilities. In fact, apart from the limits that we use, you can still count over several systems that almost everybody is using. It's not bad to use different systems, but it is bad when those systems cannot talk to one another. When they, at the end of the month, one generates something different, another one generates something different. They are not compatible. They do not conform to the standard. So that is the major challenge we have. Even within Ghana Health Service, we have RS log generating family planning data. We have MCH e-tracker, also family planning data, and they are not the same. We have DIMS itself, and we have other HAMs. In fact, even the LIMS have issues with family planning data. So fragmentation of the system that we have within the Ghana Health Service is a major issue. Now, manual data entry, actually, though we have electronic systems, a lot of the facilities are still using manual data entries. Now, you know the issue that comes with it. Some do not even have the standard registers. So that's the third issue, inconsistent reporting timelines, because the standard registers, for those who are aware of it, when some started the LIMS, they actually abandoned the use of the registers, which actually was bad at the initial stage, because you need to have a compliance of at least 80% and above you are supposed to start a system with both your manual and your newly introduced electronic system for at least 1 or 2 months. When you see that the compliance, whatever you capture manually, is almost the same as the electronic one you have introduced. You cannot transition. But in most cases, they just go and finish the training. I'm sure they will just tell the facility that, please stop. We are all going to the electronic system. Within some few days, you have issues. So it is one issue that we have. Then timeliness. Because of some of these issues we just raised, they are not able to produce timely reports. That is a great issue. And it is disheartening now because people are chasing to get 100% completeness. A lot of our colleagues simply just go and open and close them on or before 15th so that they will score 100%. Now, when you go further to do analysis, you have scored 100%. Maybe you have 20 facilities in your district. You have 100%. I go to just review your monthly vaccination reports. And truly, out of 20 maybe chip zones, only 7 of them have entered data for Penta 2, which you know, there's no chip zone the whole month. You will not have one child for Penta 2. I'm not talking about Penta 3, I'm not talking about Penta 1. I'm very sure, go and review your data. It is difficult not to have a single child for Penta 2. That simply means some of them just open and close. If that is not the reason, you may be, in fact, you may be forgiven if you say, okay, if it's not open and closed, it means they did not even provide any service for the month. So because of the timeliness, people actually just rush and open and close to be the timeliness. But let's take to the reality. Now, limited data verification mechanisms. Another observation has come out because when you go to field, you get to know that we encourage facility level to do data entries. But what is coming up is that they do the data entry, they don't submit a copy of their monthly reports to the districts. The district to say they are doing data validation. That's a very big issue. But to do data validation, you need to verify. Usually you are supposed to do it at the sub-district level where you can look at the registers and the rest. But if you cannot do that, the minimum you can do is look at what they have submitted, what they have entered. At least you may see some inconsistency between what they gave to you and what they said they used to enter the data. So it is one area we have to look at. It's good if even they do the entry at their level, that's the service provider level, and you are not able to go and do the data verification using their registers, at least the hard copy report should be with you. Now, as times go on, we will be able to use the electronic system that they have entered the data, because that one you have access to it even at the district level. If they are using the MCH e-tracker very well, you can just go and download the register and compare with what they have entered. That would have been very good. But as far as people are using manual, sometimes you need the manual registers to verify what they have done. It should be a 3-way. What is entered, what is in register, and what has been compiled. Then different health management information system forms used. That one is very clear. Some of the LIMS forms are not the same as what we have in DIMS. Some of the facilities that use HAMS, they have issues. Now you have so many of them. So that is another major challenge we have. Now, going forward, why do we do all this? What is the strategic importance or purpose for having data quality or high data quality as our priority? We say strengthen decision-making through trusted data. That we agree. Enhance service performance, compliance, reporting, because we have partners, we have policy that we have to comply with. Then improve operational efficiency and customer satisfaction. Then reduce duplication and data handling errors. Now, you see all this, there's one thing I intentionally left out, but because it cut across all. If you have high quality data, we tend to be able to do our core mandate as data managers, monitoring and evaluation. Because Ghana Health Service is an implementer. Ministry of Health make policies for us. So we should be able to monitor what we are implementing. And at the end of some of those projects or for a certain time, we need to evaluate what we do. I'm mentioning terms that we all need to be on the same scale. Can somebody tell us a clear difference between monitoring and evaluation? Because these two terms need data to be able to accomplish the goals for monitoring and evaluation. Can somebody just summarize what monitoring is and what evaluation is? In a simple term, for all of us to be on the same scale. Well, we can't do this without data. Moderator, can you get 1 or 2 people for us to all go into it?
Yeah. Yes. So who will help us? Yes. Is it Ghana Football Association, GFA? Can you proceed, sir?
Because they are almost qualifying for World Cup. You haven't qualified yet.
Okay.
Yeah.
All right. So, in my layman's view, monitoring is during the project implementation phase. You monitor the progress of work done. Then, at the end of the project, you evaluate the outcome to see whether you are able to meet the target set at the beginning of the project. That is where you do the evaluation. So monitoring is during the project phase. Evaluation is after the project has been completed.
Okay. Any other view?
Yes, Francis' hand is up. Francis, you can also unmute and go ahead. Francis.
Hello.
Yes.
Yeah, I side with the one who just made a comparison. Yeah, monitoring is in the hospital or in the health sector, you see the activities that go on in the facility, whether people are doing their work as they ought to do or are not. And then at the end of the day, you give yourself certain period. At the end of the day, you see whether indeed what they said, what they wanted to do or what they had been planned to do, they have actually done it. And how was it done? Was it done properly or it wasn't? So it's actually looking at the activities that go on in the hospital, and then you evaluate it. You bring analysis or you comment about it on what goes on. Thank you.
Yeah, thank you.
Okay.
I feel like adding on.
Okay.
Yeah, so for the monitoring phase is where the entire indicator is broken down into what we call intermediary indicators, pieces, if you want to use ordinary language. So you monitor against those intermediary indicators, so you know either you are achieving or you are likely to achieve or not. But the evaluation is when the project is done. Then you evaluate against the bigger goal, the bigger indicator, to see if you have actually achieved. So if you leave out the monitoring, you are highly likely to fail to get the goal to be achieved. Thank you very much.
All right, thank you. Senior may proceed. Yeah.
Okay. There are so many differences, and I've just mentioned some of them. But let's just, for the sake of what we do, monitoring actually, for the work we do, is just to track progress. But evaluation, mostly, people say end. Evaluation is not only end. It can be midway, it can be the end, it can be long after the project have ended. But monitoring can be before, during, and even up to what? Till the end of the project. So they overlap in the middle. So before you start a project, you can start monitoring. because your plan itself need to be what? Monitored. So that they look at the input, they look at the progress of activities that you say you were going to do. They also look at, hello, are you hearing me? You look at the input, they look at the progress, and it allows you to adjust or to modify your plan. See, that's why monitoring is very important. Before, during, and look at the activities, look at the input. It allows you to reallocate your resources, even change timelines, do some task shifting, and make sure that the project is on track. By evaluation, as usual, I look at the impact, I look at the design. So most people say you just look at the impact. It's not only the impact. They also look at your design, whether you have even implemented it as planned. They look at the efficiency, they look at the effectiveness, but we always look at impact. You can do evaluation, the impact may not be as you plan to be, but you'll be happy because, hello, somebody is distracting us, but you'll be happy with the impact or evaluation result because they were able to get you the reason why you failed to achieve the aim. So they will look at the design, they will look at the effectiveness, they will look at the stakeholder involvement, which is part of the design. So as we do all this, we need data to be able to do either the monitoring or the evaluation. And if that data is not of high quality, you are going to recommend to your partners or your sponsors or stakeholders on things that do not exist. That may be waste of resources and time. So our work is very important, though we still need more recognitions and resources to be able to carry out our work. I'll just stop here for us to get this clear. Now, what are the specific needs for a high quality data? Informed policy decisions, effective resource allocations. That was where I just stopped to look at the monitoring. Accurate disease surveillance. You do not wait for outbreak to just overweigh you before you say that, oh, we didn't know that we had. So we also have improved patient outcomes. Then example is accurate malaria data help target mosquito net distribution in endemic regions. If you cast your mind back, when they started the seasonal chemoprevention treatment, which the Northern Belt, the SMC, the Northern Belt, what we are doing now is data. They get to know that there's a certain period and a certain zone in Ghana. If you implement the SMC project, where they usually give children between 3 to 59 months, some chemoprophylaxis to make sure that they clear the malaria parasites from their system and also prevent them from getting malaria. This is data that you use, and it's actually working very well. Now, can we look at dimensions of data quality? In fact, most of us know them, but let's just all be on the same scale. What are some of the dimensions of data quality? This one is not theory, that is what we do. Can we get the dimensions? When you mention one, try to explain it. Moderator.
Yes.
Dimensions of data quality.
Yeah, Sheila, your hand is up. Kindly proceed.
Okay, so data consistency, making sure that, let's say, for instance, if we take bed utilization and then inpatient statements, you make sure that the data you have on the inpatient statement is the same as what you have on your bed utilization. That is data consistency.
Thank you.
Okay, next.
Thank you very much, Sheila.
Whose hand is up?
Yes.
Nobody's up, eh?
Samsung.
Hello?
Samsung. Yes.
Yeah, I'm trying to raise my hand, but my screen is not allowing me.
Yes, please go ahead.
So we can also talk of data accuracy. A situation where the data is, let me put it in a mail and we like correct. I am looking at ANC registrants. And then when I went further, they are asking me the age group of the registrants that I have reported. If my data is accurate, if I have 10 registrants, if I add my age groups, it should give me 10. If they go forward to ask me what are the trimester of those ANC registrants, if I add the first trimester, second trimester, third trimester, I should get the 10 registrants that I have reported. So that is about the data accuracy. The data should be accurate. It should actually measure what it is supposed to measure. Thank you.
Okay. Francis Ahadomi.
Yeah.
Okay. Also, we can talk of 10 minutes.
Mr. Francis, we can't hear you. Can you speak up a bit?
Yeah, all a minute. We can talk of 10 minutes.
Mr. Boy, did you hear?
I don't think I heard him well.
Hello.
Yeah, hello.
Yes.
We can talk.
I think his network is disturbing him.
Yeah.
Okay, let's boss on. I think he will have another time.
Yeah.
So, dimensions of data quality, as they mentioned, it should be accurate. Accurate simply means your data should correctly represent what it intends to be. If it is 20 ANC mothers, it should be what? 20. You should not go and have something different from what is supposed to. It should be accurate and should reflect the true situation. Completeness means all required data elements are filled. No missing values. So in Ghana Health Service, our completeness may not necessarily be one way. You will have completeness if I'm thinking of the number of expected reports you were supposed to submit at the end of the month. If you are expected to submit 13 reports and you brought only 12, it is not what? Complete. Again, if you even bring all the, assuming you brought all the 13 reports, let's assume that you brought all the 13 reports, but I check in one of the reports and some of the data elements were not filled, it is still incomplete. So you can look at completeness in terms of the expected data sets and completeness in terms of what? The data set themselves, the fields that they were supposed to, or to be, you were supposed to fill all the fields and you didn't fill. So in completeness, let's look at it in two ways. So now, headquarters have designed DIMS in such a way that those who just go and open and complete, because the data set completeness, there's a level of analysis now that is going to analyze the mandatory fields. So it will not, you allow you to go. Let me give you an example. If you say you have filled your mobility returns, you have achieved 100% completeness in terms of data set. We all know it is difficult for a major hospital in Ghana to say that you do not report a single malaria, suspected malaria case. So you can run for total malaria, uncomplicated malaria suspected. If you run and you do not have it, maybe 3 out of the 12 months, we definitely know that you do not fill your data for 3 of the month. So that model has been designed, and I think it's working in some cases. There is a recent meeting we went, they populated it. So watch out. Don't just go and complete your data set until you have completed. We are looking at data element completeness. Consistency is uniform across different sources and formats. You can look at, if you say you have somebody mentioned, even within the same data set, we can look at ANC registrants, 10. We look at the age group of the registrants. If I add the various age group, it's not up to 10. Internal consistency is 0. We may look at deliveries. You say you have delivery this, and we go and look at which form have deliveries. Let me say CS. You have your CS cases, and we go and look at essential obstetric care, which every pregnant woman that you have done CS, you are supposed to fill that form. So if I go and look at your essential obstetrical care and the numbers there are not matching up with the number you put in Form A, there's no consistency. So there are several, you can look at internal consistency and external consistencies. External means outside the forms. And you look at other forms that have related. The same thing for malaria. Malaria in the anti-malaria reports and malaria in the morbidity. So let's take note. Consistencies are in different forms. Then timeliness, we have deliberated on it. Timeliness, we all know we have by the 5th of the month, all the facilities should have submitted their data. By the 15th, the district should have also finished their data. By 25th, I think the region 2 should have done all their review and validation and everything. And after that, the data is deemed to be used by national and other partners. So we know these timelines which we have to comply with. However, there are some that do not go by these timelines that I just mentioned. For emergency or epidemic prone diseases, some are 24 hours. Some they even say immediately, not even 24 hours. So let's take note. Depending on the context, there's timeliness that have to be adhered to. Validity, data conforms to defined format, ranges, meet business rules. We have standard for almost all the data metrics that we use. So it should be valid. It should truly represent what it's supposed to measure. So let's look at it. Then uniqueness is something that some people add, some do not add. But uniqueness now is becoming a big issue for us to all look at it. No duplicates. If it's unique, you will unique, especially when we are looking at longitudinal data, where you have a client's records. All that is there, and that client should have a unique ID. In case you want to do further analysis or isolations, you can call on that ID and be specific of what you are looking at. Thankful, we have health insurance numbers that are unique. We have national Ghana card numbers that are unique. We have SNP numbers that are unique. We have telephone numbers that are unique. My brothers and sisters, the problem now we have is S. At the various OPD, our colleagues that sit at the OPD, do they fill all these variables? Those who are using manual, go and pick one of the folders. You see that they do not fill all. Meanwhile, the clients have them. Go and look at limbs. They do not fill all this. Meanwhile, most of the clients have them. Please, let's try filling them. It is only when we fill them that we can easily identify some of these clients when their need arises. So uniqueness is very good. So they serve as primary key when you are doing further analysis, especially with big data analysis. And we have volumes of data that as time goes on, we'll be using the big data analysis for most of them. Now, when we put all this together, we can summarize all our challenges, issues that affect data quality into one, human resource factors. Either we do not have the required skilled staff, or we do not have even, they are there, but the trainings, they don't have the capacity to do it, and other related ones. Then we have resource constraints. Some of the work that we need to do to actually have high quality data, we need money. We need money to get the resource. Somebody complained of internet service. You need money to buy it. Recently, government actually extended free internet to a lot of the hospitals, district health directorate and regional health directorate. I won't say all, but I know a lot of them, they have the free internet service. When we went to field, you know what happened? It's very clear. It's only ended at the IT unit in most of the hospitals. They just extended the line to the IT unit, they drop it, the case closed. Yes, that is a national policy, but the facility mandate is to extend it to the various service point where the internet is needed. So my colleagues, when you go, those of you that they brought the broadband or the spectrum to your facilities, go and check. Most of them, they left it at the IT units. Make a case for them to extend it to your unit. If they will not send it to the other unit, make a case for it to be extended to your unit. Some HIs, when I follow up, they didn't even know that they have free internet service extended to their facility. So it is there. Let's try to use it as a low-hanging fruit. Then we also have technical or infrastructure challenges. Just as I mentioned, some need more infrastructure to extend the IT, the computers, the laptops, the tablets, and other things. That is also okay. Then organizational processes. We have bureaucratic processes. We have some units that do not actually even value the work we do. They pretend to value, but they do not value. This also affects data quality. You call for data validation meeting, they will not come, but they say you should send report to the region that data validation has been done. This one shouldn't happen. And that is what has happened. They say send a report so that when I go for appraisal, they will not say that me, the district director of medical school, do not do. But you knew very well they are not supporting you to do data validation. So some of these organizational processes actually also affect our work. We can't overlook it. Now, when you pick the human resource, we have issues in terms of training and capacity. Some staff you train within a short time, they are gone. And the few there are also overloaded. Some of you are overloaded, just like me sitting here. Some of you are overloaded. Some too, actually, they come, you take time, build their capacity, they are gone. I can remember for the past 4 years, no HR have been employed in the system. All those who finished, I think the last batch we received was 2018 batch, or 2017. And we actually received them in 2020. Not even all, just few of them. A lot of them are at home. So when they keep long and they even happen to get into the system, like you need to do training all over again. It's a big issue. The technical infrastructure factors, we just talk of internet, outdated software systems. In fact, LIMS is supposed to help us, but now it's a big problem. For about a week or two ago, I think a lot of our facilities have having issues. Even yesterday, some were still calling that they had issues. But let me also say that we have issues with the LIMS, because when they go to your facilities, they relate more with the IT units than the health information officers. So when they leave, some basic things that you are supposed to do, you are not able to do. That's a fact. And it's a dual way. The HIs are supposed to look at the data aspect, and the IT personnel, they are supposed to look at the IT infrastructure. So most of you are not able to explain well to your medical schools or superiors that you are not rivaling one another. One is for IT infrastructure. One is for data management and the reporting. So when they come to do training or to do whatever, they too are needed. If you do only one, the system will work, but it won't work up to its optimal expectation. Now, the third one is resource control. I mentioned budget issues, equipment, insufficient staffing. That one is okay. And the last one, the organizational process, we look at it. Supervision. Now, let's look at supervision. I am, in fact, particular about this issue because the LIMS, please, when those are the hospital and the health centers running LIMS or other electronic health records management system, please take note. When you go every day, you are supposed to just visit those who are providing their services at the various terminals. See how they are, some are just doing things they don't understand. See how they are doing it, then go back to your office, run analysis, a report for that specific day. If I go to my office at the hospital and I run analysis for consulting room or mobility, you just go and download the consulting room register, then do mobility for that particular period. Maybe if it's 2 days, 3 days, just do it. You will see a lot of gaps. Now, you know that somebody is sitting at the consulting room that particular time that you saw the gap. The person is not putting the, what do they call it, suspected malaria. The person is not putting the provisional. He's not doing the testing. The testing rather go to the history table and they go and do. Please, LIMS does not accept it. Because it is structured in such a way that it is the prescriber that should request for the testing, not a history. Those are the history table. What their accounts is not linked to the mobility. So let's take note. They do things, you said the thing is done, the patient have received all the service is gone, but it's not in the system because the one that is supposed to do is not the one that did it. So it's like you have done manual work. Lab will see it, provide the investigation, the patient get and go, but the mobility will not capture it because that request was supposed to be done by the prescriber. So when you do and you see that that is the problem, you just go to the prescriber, oh, please, these are the issues. You are supposed to do this and this. That's all. So let's take note. Our work has been reduced with the electronic system, but we need to monitor and prompt those provided. If not, it will be garbage in, garbage out. The system seems to be working well. It's just utilization issues that we are having. Now, some of the common sources of the data errors. This one, we are all privy to them. We have the policy-related factors. We have people-related, as I mentioned. We have the facility-related factors. These are the organizational processes and other issues. Then we have the procedure-related factors. The procedure actually can also be part of the people-related. If you don't follow the standards, what is supposed to be done, you will not get it. So the procedure-related and the people-related factors are almost the same. It's the same if you are able to work on that. The policy issue, you and I cannot do much about the policy issue. So the human issue and the facility-related issues that if we work on them, we can improve on our data quality. Now, low quality data can lead to inaccurate diagnosis. We all know. Delayed treatment and even death of the patients. The policy issues are there. We will not go too much into them. But we had the lack of the standard registers, which we know we don't print. They have to come from above or from the partners. Lack of standard reporting forms. Yes, when the forms finish, they have made changes to the old one, and you have people are still photocopying the old ones. Then lack of job aids and SOPs. We try to have our SOP, but remember the printed version we have is still the 3rd version. The 4th version that came never got printed. The 5th version is still under review. So it is encouraged that we all have at least the 4th version, the soft copy. Let's get the soft copy and distribute to our colleagues and let them have at least the soft copies. Now, the second issue is we have the SOP, but we do not use them. I'll just mention 3 key issues in the SOPs. We have report submission logbook and report receive logbook. You are not using it. That's the only evidence to show that you are looking at the expected report and they actually brought it and whether they brought it timely or not. So this one, the report submission logbook and report receive logbooks, it is in the SOP. Just photocopy it every month. You fill it so that you can track the gaps. Then we also have data change request form. Anytime data is locked, that's after 60 days, you fill it and submit to the region. They will add the covering letter. In fact, you have to let your medical soup or district director add a covering letter to the form you have filled. It comes to regional director add a covering letter, then we submit it. They call you to effect the changes. Please, we are supposed to have a file with empty copies of the data change request form and filled copies of the data change request form. So it is up to us, all of us, we are supposed to have files for that, whether district, hospital, or region. In fact, region, we don't need it. Well, we are not supposed to make data changes. District and hospital, we are all supposed to have a file for data change request form. Now, there's another one, data request. It's no data change. Some people needed data from you. They just minute to you. They need this data, you provide. Without filling a form and keeping it. We are all supposed to have a file for data request. Anytime they request for data and the experience asks you to provide it, you keep a copy on file. Please, let's take note. The other logistics issue, we talk of that. So let's keep on. Now, the last one, I want to gloss over it, but that will be injustice. You see, the lack of tablets and computers for the EMRs. I know, we all face it. Sometimes when I have issue with my machine, it takes time before I get it. Sometimes people we use our personal machines. But let me give you a trick that we have all learned from. When you tell managers that, oh, we need this, and they are not providing, the next time you repeat, they are not providing. What managers fear most is documentation. Put in a memo and write and submit. Everybody should have your plan, your annual plan, things that you need. Write it, put in your plan, take them one by one, those that you need, write it in a memo and submit and keep a copy. If they ask you to bring, don't go and rewrite a new memo. Repeat that same copy. So that when they get to know that you are documenting the issues and they cannot blame you when things do not go on well, they tend to act on it. Please, don't go and say verbally that, oh, we want this and they are not money every day. No. Put it into writing, sign, keep a copy. So let's do that. Now, the people-related issue, we've talked on them because we don't have much time. I will not go detail into people-related, but we have the insufficient training of health workers, numbering and correlation errors, inadequate supportive supervision, which I just mentioned. On a daily basis, those at the hospital, please just visit the wards, look at what they are doing, compare with the standard, so that you'll be correcting those who are not doing. Because they have people doing orientation, people doing national service, people who are even older, but they still do not understand the system. So we have to continuously be doing that so that when they get to know, they will teach the rest. Limited use of registers during service delivery. We all know. In fact, the thing that is even making things worse now is that we say we do not have funds to print registers. National lobby with partners to introduce MCH e-tracker that is supposed to replace the manual registers. People are not even using them. So we are now in a dilemma. We are going electronic, people are not using, they are holding the tablet, they are not using them. But most of them just because they still do not understand how to use it well. So let's try to assist them to do that. Now, no use of data for decision making. We keep on pushing. You give them something that they don't use, but keep on providing. That's our work, the feedbacks. Now, facility-related issues are just similar to what we mentioned, because the human ones are also in the facilities. Improvised registers, heavy daily workload, use of untrained staff for data capture. Previously, any person that is not doing his work well or doesn't come to work frequently, or they say should go to the records unit. When they go there, matters even become worse. So heavy workload too is another issue that we are battling with. Procedures, we mentioned a bulk tallying of data, inadequate data validation and verification, late reporting, and there's some report. Every report is supposed to endorse before you submit, and you keep a file copy. Data validation without the use of registered and facility, which I mentioned earlier on. These are our procedure-related issues that if we improve on them, data quality should improve. Now, for the accuracy issues, we talk of the estimation instead of measurement. Some of them, instead of they just guess, it's guesswork some of them are doing. Transcription errors, another issue, memory-based reporting. Some of them, because they have not documented the exact service they provided, they try to recall, and you know, we have recall bias. Those errors that arise out of long things that you can't even remember exactly what you did. So these are some of the accuracy-related issues. Completeness, skipping optional fields, as I mentioned, lost paper forms, incomplete referrals, and those things. So completeness, internal and external, then the data set issues, just similar to the consistency. Look at the external consistency, internal consistency, and make sure things are actually in sync. Timeliness, we've already talked on timeliness, delay data collection, batch processing. Batch processing. There are some of the reports you have to actually summarize them daily or weekly. You do not wait till the end of the month. Usually the workloads become too much on you, and the human mind cannot be consistent for a very long time. So let's try to do like weekly summary or monthly or twice weekly summaries. I'm sure that one will be better. So let's work on that. If you do that, it will delay it will improve the delayance, so that our timeliness will improve rather and reduce the delayance. Now, validity, some are using outdated, in fact, let me just with the out of range. Now, the GEMS to have this, when you write data validation, minimum and maximum values analysis, it will tell you the outliers. So the outliers are a way of getting this out of range values that you have been entering. Some may be mistakes, some may too, they're actually correct. It's just that you have to give reasons for it. It's not all outliers that are wrong, but let's look for them so that those that are wrong, we can correct. Those that are correct, we look to get the reason for that outlier. Getting the reasons are very important. The invalid code. Invalid code, when you go to the mobility, cause of death certification, please, let's all use the ICD 11 codes.
with the food. What are you trying
Let's
to
refer ICD 11. We have the online version. I just go and type who.int. Then maybe when you go there, you see the /ICD. When you see the ICD 11 online version, any disease that you want to put in the cause of death and you are not too sure, or the doctor have put by, just go and tap it. It will filter so that you pick the right condition and put there. When you pick the right condition, then during the entering of the COD, use the filters. Do not tap the manual one. Manual one tap. But when you go down, you see the filter. The filter give you the WHO standard diagnosis, so that we will not go and put things that will not match. So they can also be classified as out on range. Uniqueness, we talk of uniqueness. I will not talk too much about it, because if you use LIMS and the other system, it give you unique IDs. But just also make sure that you also capture the other IDs that are necessary. Now, towards the end, we need to address the data quality challenges. And that's why we are even doing this presentation. Now, I will actually take something before I conclude with that. Can we look at how we address all these issues that we just talked of? How best do you think we should address these data quality challenges at our various work areas? Moderator, can we come back to that?
Yeah. So how do we address these data quality challenges? Any suggestions? Or what are we doing in our various workplaces to resolve data quality issues?
Because we have been doing it and we have been solving some of them. So let's see what we have.
Yes. So should I proceed?
I think that having more in-service training will help.
Okay. In-service training. Evans is also saying hands-on training of personnel. Any other? Yes, Samson, you said?
please? Good evening.
Good evening.
Okay, since we didn't mention of supervision monitoring. So what I want to add up is when we go there, when we identify any gaps, we have to do action plan for them. And then after the action plan, we need to go down and see if what we expected them to do, they'll be able to do it. Thank you.
Very well. So we need to intensify supervision. And we should not just go and then watch things and go away. We should come up with pragmatic measures in the form of action plan to address the issues, and then we monitor the action plan. Good. So from Mary, that there should be at least monthly or quarterly refresher training. Evans also mentioned supportive supervision, coaching, and data validation has also been highlighted. Yes, so Ahadomi Francis, let's hear from you.
Yeah, please, can you hear me now?
Yes.
Please, can you hear me?
Yes, you are allowed.
I think we need to also improve our data collection processes.
Okay.
Yes. That is to make sure that we use standardized tools in collecting, the data. Because the quality starts from the source documents or where we are collecting the data from.
Very well. Thank you. Thank you very much. Senior boy, I think we can proceed. Yeah.
Thank you very much. In fact, you were all on point. Now, let's look at the accuracy issues. For us as a country, or Ghana herself to move forward, we need to implement automated validation rules. Remember some time back, DIMS, if you made any mistake in any other form, it will flag that maybe validation route not successful, and it wouldn't allow you to even proceed. But because of restrictions and others, those validation rules were relaxed. so that if even it's wrong, it will prompt you and allow you to to save your data. And later on, you now go and run the validation rules and correct. Unfortunately, because it was just to rely the system for people to be able to enter the data, people do not go and write the data validation analysis. You know, in DIMS, there's a model for data validation analysis. When you run it, it will tell you all those errors you have. It's not actually not all. Let me say some of them, because some of the rules are not working. At least it will, for malaria, I think from a family planning, mobility, I think statement of outpatients, that one it will flag them for you. But we do not go to look at it and correct. But if you go and the things are there, you are not correcting them, then actually it's as good as not even going there. So some of the automated validation rules are there, but we are not using them. And some too actually are not there. Majority of them are no more there. However, we can export our data to Excel and build our own validation rules. So it is a semi-automatic. The DIMS file will have been fully automatic, but you can build your own validation rule using Excel to just flag those areas that are not correct so that you can work on them. One simple example is you can download for all your facility in the district, you can just download total OPD attendance versus total cases for all your facilities. The moment you have a figure in total OPD attendance and you do not have a figure in total cases, you know that statement of outpatient has been entered, but mobility has not been entered. So sometimes that's the trick we use at the regional level. We look for some proxy indicators and run for all and see those who have actually truly entered the data or not. So we can do it in the absence of automation, but nationally, they should try to automate most of them. Then we also have established data quality audits, which we actually think per the SOP, we should all have data validation teams. The mobile data collection tools, that is why the e-tracker, MCH e-tracker, TB e-tracker, HIV e-tracker have come. That's the mobile collection tools. Now, we are not using them well. So let's all make sure that we take the service providers through, monitor them, coach them so that they should be able to use those tools. If they do that, and we also keep on looking at their reports and giving feedback, accuracy is likely to improve. Now, completeness, if you look at the mandatory field requirements, there are some forms, you know, if you just say that you haven't done this, you know that the work is not done. So completeness, we can look at LIMS. Are they actually filling all the expected fields for a client? LIMS have relaxed some places, though it's mandatory, they didn't force it to be mandatory. But those prescribers or service providers should know that those things are mandatory for all clients. So let's keep on reviewing it on a daily basis and go to those providers who are not filling the thing completely and just prompt them. The more you keep on prompting them, they will teach others. E-tracker, the same thing, the tablet. When you don't use it very well, you will not, it won't even allow you to sync the data. So completeness, using the mandatory field is also good. RS log have similar issues. Then we look at our logbooks and the checklist using the SOP. I'm sure if you use all this, we should be able to improve on the completeness. Then we can also automate the completeness just like the other one. Then do follow up on missing procedures or missing data elements. Then regularly do data quality assurance or assessments. You can just pick some few things and go and check, compare with what they have against what the system have generated for you. With all this, using the SOP, we should be able to improve on the completeness as a strategy. Consistencies, you have to standardize definitions. And luckily, most of the indicators or data elements we have, the holistic assessment tool have some definitions for them. If you pick the SOP tool, most of them have been defined to just help easy understanding, except the new variables that have been introduced after the SOP was developed. But most of them came with addendum on how those definitions are. So because of that, DIMS now have introduced data element definitions. So take note, they are all there. Data element definitions is in the new version of DIMS. Maybe most of the RHIOs we will try to orient our subordinate to be used to it. It is there. It is now in DIMS. So explore it. It is part of it. You look at the definition for most of the data elements so that you don't need SOP when it is not available or closer to you. Then you need to look at the various versions of the tools that you use. Some may be using old versions. So use the new versions and get the new definitions. That will be very good for you to improve on the consistencies. And look at the cross-system validation from different, maybe LIMS against those that are in manual and maybe those that are in HAMS. Some of you are using different systems. And we also have the lab, also using another new system, different from LIMS. We need to look at all of them. Now, timeliness strategy, how we know, real-time data reporting, you should report on time. And most of the electronic systems are real-time if you actually use them. Well, we can also automate reminder system. But let me just tell this. Automation of reminder system is not only the EMR, even our phones. We have calendars that we can automate. So sometimes I automated most of the routine activities using my phone calendar and put alarm. So I know that every week I will do this, I automate it. It reminds me. If you are not able to do, at least I reminded you, you postpone it. So reminders is not only the DIMS reminder, but DIMS will have reminders. You can do all those things. Then you take some key indicators that you want to look at, build your dashboards. You know, the dashboards also serve as a reminder for us to know what we are supposed to look at, because we have a lot of work to do. You can build dashboards, DIMS dashboards, or the line list dashboards, build them and summarize them so that when you see any unusual pop-up or figure that you think is an alert, you go and look at the details based on the summary that it has given you. Validity strategies, data quality standard framework, and data quality standard framework can only be useful if you are using the SOP and you are actually looking at your data through data validations meetings. Then we also have a performance rating feedback. We can look at most of this validity and accuracy and consistency issue if you are giving two feedback. One is data quality feedback. One is performance feedback. Indicator performance feedback, just few of them, and data quality feedback can all give us signals to anything that is going wrong. You reward the good ones, then you also support those who are not able to perform. So these are very good. And let's use the validation rule analysis, the minimum and the maximum analysis rules in DIMS. It actually look at the range issues, look at outliers and the others. Please, let's look at them. It will support us to minimize the validity-related challenges. Uniqueness, we all know, we say let's do unique IDs, fill all those that are there. Some are not mandatory, but fill them. They require for telephone number. If the person have no telephone number, put a relative telephone number, because you can reach out to the person using the relative. They are all things that we need to look at. And some are just low-hanging fruit. Health insurance, Ghana card, phone numbers, wherever it is needed, let's make sure they are, and it should not be duplicated. Now, to end with this, what is that? What are the take-homes? One, let's all develop our data improvement plans. We are just doing budgeting. Please, every unit should develop your plans and budget for 2026. If you are the hospital, make sure your plans and budget, data quality management issues are part of the hospital budget they have submitted. If you are the DHA, you do everybody's work, but make sure your own work is part of that work you are doing. Data improvement plan or data quality plan, it should be part of the budget. Then you follow it up. The information of functional data validation teams at all levels, it is part of the SOP. Let's make sure they are formed. Those that are not supporting you to implement them, do not force and write report that you've done data validation. Say, I've done desktop review on my own, but we couldn't hold our data validation meeting. When you do that, the manager will set up. But when you cover them up that it is done, when you know it is not done, that is not a good thing. Data validation feedback, if you have done, you have to give feedback to the lower level. for them to look at the action areas. Then coaching visit to service providers, as mentioned by some of our colleagues. Regular coaching visit. Not all of them need money. If you are at the hospital, you don't need money to go to a ward. Sometimes district, you go to sub-district to do some work, not part necessary data quality improvement work, but you can take advantage and look at 1 or 2 registers, look at their reports. And now, the relevant dashboard in DIMS and event models. Let's build dashboard. Key things that you need to be looking at regularly. It could be the reporting rate, it could be timeliness, it could be completeness, it could be some service indicators. It could be mortalities. You just want to look at only mortalities. Build a small table or a chart or a line graph, whatever you want. Build it so it will serve as an alert for you. Then you do same for the data entry dashboard. Then you give feedback on performance to your superiors and managers. Very, very important. As you give feedback on data quality and performance to the lower level, you give to your managers because they can enforce some of the issues that you want to be resolved. But they have the weight. When they say this, they respond well. So you give, sometimes when things are not going well, the managers come in to support. Then you need to have some small operational research in relevant areas that may unearth data-related issues. You can just do something. Recently, we did a small one when we were just about having the half-year review. We just look at the actual neonatal deaths, stillbirth, and maternal deaths that exist in the LIMS and their manual register as against what they reported in the Form A. You'll be shocked what we saw. In fact, people are patching up stillbirth, people are patching on neonatal deaths and the rest. You know, because of holistic assessment and others. So we are to go and just, when you do that, they know that you are looking at them. They start reporting the reality. Then build the capacity of service providers to own and use service data. You see, initially, it looked like it was our back. We know that let's build their capacity so that when they get to know the importance of why we are asking them to report or document, they'll be using it. When they use it, it makes work easier for us. It's like task shifting because we don't have enough staff. So let's build those capacity of those who can do the work. Some community health nurses, midwives, ENs who are willing to do the work, build their capacity to do the work so that we concentrate on very technical and key issues that they may not be able to do because they are not trained for that purpose. And finally, continuous learning and practice. Whatever we do, if you don't put it into use and practice, you will forget. Especially in the new era where we are into the digital world. You learn something, you don't do it, you forget. Go and learn QGIS. You don't use it for about 3-4 months. You will not even know how to draw a map. You go and do some small Python, for 4, 5, 6 months, you have never used it to generate any data out of your CSV file or this thing, you forget. So whatever you learn once in a while, make it a routine that every quarter I will do something using this. In my feedback, I will use 2 or 3 of the slides as a map. I will use QGIS to do it. I will use DIMS to do this. I will use pivot table to do this. So when you do that, it becomes something continuous. Continuous learning is something that we have to encourage. And if you are able to do all this as our takeaway, we believe that we will achieve our purpose. So in conclusion, high quality data is fundamental for effective healthcare delivery and policy formulation in Ghana. The multidimensional approach to data quality ensures comprehensive improvement across all aspects of health information management. Multidimensional. Let's use all avenues, all sources, all stakeholders, and make sure that we have achieved our main mandate to make sure available and quality data is at the disposal of our managers, disposal of service providers for the benefit of the client. We are supposed also to implement and recommend strategies that requires coordinated effort between policymakers, senior managers, and frontline health information professionals. We need to coordinate. Continuous monitoring, regular training, and adequate resource allocation are essential for sustainable data quality improvement. Let me emphasize, you will never get enough funding, but let's do with the little that we have. Sometimes that little may bring the extra that we needed to be able to accomplish our goal. And the last point says that by prioritizing data quality across all the levels of health system, whether sub-district, district, GHA, RHA, whatever you call, we should be able to cut across all. Ghana can enhance disease surveillance, improve patient outcomes, optimize resource allocation, and ultimately achieve better health outcomes for all citizens through evidence-based decision making. That means simply, if we do all that we are supposed to contribute, we will also support in achieving universal health coverage by 2030. That simply means primary healthcare service will improve if only we want to achieve universal health coverage. On that note, I thank you all for your patience, and I'm sure some of them have issues they want us to discuss before we finally call end this presentation and close for the day. On that note, I'm open for questions and other issues that will need further clarification. Thank you very much.
Thank you. Thank you very much, Mr. Etowe Boy Yakubu. We are grateful for sharing these insights. So the floor is open. If you have any question, you can proceed to raise your hand and we'll respond to that, or you put your question in the chat box. Let's be snappy on this. Any question, any contribution? Yes, Mr. Ephraim.
Correct. Senior, good afternoon.
Good afternoon, boss.
Afternoon.
Yes. Right. Senior boy, good afternoon to you.
Afternoon. How are you doing?
Yeah, we are fine. I nearly missed this opportunity. Yes. So thank you very much for the elaborative message that you have put across. Now, a few things that I want us to probably recognize or acknowledge. One is that, you see, we the HI officers in health facilities, I should say facility levels, sometimes we think that we know a lot, but we know a little, and that is a fact. I am saying this until when myself and my boss, we managed to, as it is, plan a very good way of making sure that the IT department, that is, so to speak, currently handling limbs in our facility, drawing his attention or his scope of work hours. How do I mean, or what do I mean by this? You see, if you allow them to operate, they will operate and then eat into your description, job description, I should say. And that we sat our IT guy down and then told him that, Master, we are working, the difference between HI and an IT is the HT. It's okay. That is the difference. And the ultimate goal is to ensure that at the end of the day, if I am going to start my work, the work should still end with me. I mean, I will start registration, and then as you said in your presentation, try to give feedback in a form of an organized analysis or data to these individual stakeholders. So let's find a very good way of explaining things to these IT guys. In my facility, as an example, you cannot create or open a bed in the limbs without informing HR unit. You do it at your own peril. In my facility, you cannot create any directory or unit or procedure within a system without informing the office of HI. You do that at your own peril. But if comparatively you are not seeing that from other facilities, then it means
HIs over there are doing something that is not conforming to the standard. Communication, I should say, is a key in this regard. Let's not leave out our description, what we are supposed to do in the system. Let's not leave it out for IT guys. Of course, the facility will come against you, the HI person, because they think that once it is infrastructure, once it is a system, then it should be managed by IT. But I can tell you that we HI, if you understand the system well, if you know your left from right, yes, even the IT guys will now come to you for clarification and then for some redress. So please, let's learn. Let's learn. Let's try as much as possible to understand the system that we are using. Otherwise, you do whatever presentations, you do whatever data analysis in front of your medical suit, your district, whatever, they will not appreciate it because in their mind, they know that you don't know. Now, Senior Boy, one thing that I want to also add, and that is a question. Since 2012, that I came into contact with DIMS proper. Yeah, specifically, maybe I started with data entry. I have not seen this indicator. I don't know, maybe it is hidden somewhere. Turnover interval. I think what you see in there is turnover rate. But for turnover interval, I should say bed specific, I am not seeing that. Is it hidden somewhere that you can assist? Thank you very much. And I'm grateful.
Thank you very much. So the question is turnover interval. Where is it in DIMS? Thank you very much. Mr. Kwabena Ajay Safo. Hey, my boss. Kindly unmute and ask your question or make your submission.
Okay,
Alaji
can you hear me?
Sofo. Yes, you are allowed.
Thank you for the opportunity. Senior Boy, thank you very much for the powerful presentation. We do appreciate it. Thank you. But I just want to add a little to what Senior just said, especially my brother who just spoke. You see, the HI is not a person who stays in Ireland. So you cannot do the work alone.
Safo, your voice is, we can't hear you. Okay. So I think you have to come again, internet.
Manda or this officer has asked me to do this thing, but I don't have any idea. But if you don't know and then you say, and you are not able to produce, they will tax.
Alaji Sofo, we can't hear you. I think you have issues with internet. All right, he's even dropped. And so, quick one, Senior Boy, kindly respond to the question on the turnover interval. Is it in DIMS? Is it not in DIMS?
I hope you can hear me. Hello.
Yes.
Turnover interval in fact, because it's not part of the regular indicators, I can't say whether it is there or not. But what I do know is, anytime I go to DIMS and I'm not able to get what I want after searching through, there's an easy way to do it. There's something called calculator field. I don't know whether it looks like a lot of people are not used to it.
Yeah.
When you go to when you select indicators, instead of don't go to data element, just select indicators.
Yeah.
For the type. You will see among the things that pop up down, you will see calculated field. when you use the calculated field, you can do anything of your own. That's as far as the baseline data, let's say the underlying data, the data elements are there, you can calculate it. So if you want 10 over interval, basically you can use it and go and select the statement of bed, that's bed utilization, and pick the variables and do your calculation. It will just do it for you. So most often, me when I go and I search, I'm not getting things that I want, I just go and use and do my own calculation. But I need to refer to see whether what he's talking of is there or not. But if it's not there, my brother, use the calculator field. It will just work it for you, and you are free to go.
Yeah.
But there's no much time. If now I've just demonstrated.
Yeah.
It.
Thank you very much. I mean, 10 over interval is not there, but we have 10 over rate. I mean, which helps in making decisions that have to do with the 10 over interval. So I think they prioritize the 10 over rate over the 10 over interval. Okay, so now let's take some from the chat box. From Emmanuel, it appears that the courses we study vary depending on institution. Is there a way to ensure we are giving the same training, especially regarding data management components? Yeah. So I think that is that. Currently, as a country, we don't have a standard curriculum for the training of health information officers. And then you see the courses that are being run. I mean, it depends on the institution. So you will see Legon is running a BPH, and then you specialize in health information. So you come out with a Bachelor of Public Health. The same thing with UHAS, right? Then when you go to UCC, you have BAC Health Information. When you go to Yanfo, you have, so currently as it is, that standardization is not there. And so that is why leadership is working to ensure that together with the regulator, which is the Allied Health Council, we are able to get a standard curriculum for health information training in the country. I don't know whether leadership have something to say in addition to this. General, Mr. President, Madam Dora, Eva.
I think that's okay.
I think Jalilu hand is up.
Your response is okay.
There's one hand up.
Okay, thank you very much. Yes, I will come to the hands. So from Unicent, nice presentation. My question is, there should be a refresher training course either twice a year or on DIMS to enhance our skills and be abreast on the use of data. Okay, so I think this is not a question, it's a request. That training on DIMS should be something that should be done within the year for health information practitioners. We've taken note of that. So this is from Festus. Festus says he enjoyed the presentation and wish to have more of such trainings. And I will also want to thank GHIMA executives and the facilitators. Thank you very much, Festus. So who updates price in the LIMS system? Who update price in the LIMS system? So this is a question that is coming from David Abbey. Senior boy, take note of that. And I think the rest are just a commendation from the chat box I've seen. Okay, so from Walter, great presentation. Please, are statisticians in Ghana Health Service mandatory to get AHPC pins? I am an active member of GHIMA, but without a pin. Okay, so I think we addressed this issue yesterday. Once you are a health information practitioner, you should be licensed to practice. And so whether your background is statistics or biostatistics or health information from Kintampo or from anywhere, once you are in that profession, you should be licensed to do so, regardless of your background. So please, if you don't have a pen, make sure that you pursue that so that you are licensed to practice. Okay. I think that is that. So senior boy, if you can respond to the issue about limbs. I don't know if you have a message on that.
Okay, let me just add to what I know about it. You know, before they do any setup, they usually request for all the services that the facility is providing. I remember when the Northern region, we have to coordinate it, and all the facility HIs linked with their administrator and accountants, and they provided all the services. Because they have linked the system to health insurance. You know, health insurance have standard prices. You cannot have your own prices. So they have, I think most of the prices upload is done for national. That's what they do. But there are some few requests that they have trained the IT personnel to be able to update. But those that are common, I think it's done at a central location. Because they are using the national health insurance price list. Then the rest that are outside it, I think they allow the IT personnel to take care of that.
Okay.
That's all that I do.
Okay, thank you. Thank you very much. I saw Honorable Dalali's hand up. Honorable Dalali.
Yes.
Yes.
Moderator.
Yes, boss.
I think this evening I should give you super moderators.
Thank you.
You know, I was going to ask you to find out if members of the accreditation committee, education and accreditation committee are here to listen to the requests our members are making regarding training.
Yeah.
So if you can find out for me, I will be glad.
Yeah. I'm aware the chair is here, Honorable Fumado. Honorable Fumado, you and your team, I hope you have heard the request from the member concerning training.
Yes, sir. I've heard it all and I've taken notice to consider them and work on them.
Okay.
Thank you.
Okay, all right. Thank you. Thank you very much. We are running out of time. I think I will take the last 3 hands I have here. So let me begin from Jalilu. Jalilu, proceed. Jalilu, kindly unmute. You rather on your camera. Kindly unmute the microphone.
Yes, thank you very much. So my issue have to do with board's presentation with regard to compliance. I mean, user compliance vis-a-vis we have information officer working at the facility level, giving our support to the service providers at the various service point. So here's the case, even though we mentioned it, here's a case, the administrative right of the LIMS have been given to the IT personnel in terms of the access. So when you come to some of the facilities like mine, you see that we all have access to LIMS reports, and then LIMS reports, and then medical records in terms of registration for those are the medical records. So in fact, it's a big challenge. So there are so many things we know. We have so many things on the system that we needed to exploit as health information officers, so that when we are emphasizing on compliance, I think you can use that one as a backend. So that have to do with trainings, as my colleagues have requested. So we need to equip ourselves as health information officers. We need to take on board the LIM system and train ourselves very well so that we can take charge in terms of providing support services for our data is concerned, not networking. So that an issue with data quality and then data improvement with regard to my board presentations will not be a challenges that we are facing. If not, that we will continue to talk about this. So my final request have to do with, as a GHIMA, we need to take it upon ourselves so that we'll study the LIMS very well and then build our capacity so that and then we can move on there for as data quality is concerned. Unlike previously, we're doing manual collections. So those ones, like even though the workload was too much by then, but at least with regard to data quality, there was improvement based on those that we managed to report during that time. But now that we are seeing LIMS, I think the challenges are getting too much. So we need to actually speed up so that we can resolve it. Thank you. So I need board or the team to actually say address us regard to that, especially with regard to our administrative rights, part of the LIMS is concerned. Thank you, and over.
Very well. Thank you very much. Senior Boy, I hope you have taken note. Let's take the other two before you respond to. And let's try and be
Anas,
Yes, yes.
I think I need to clear this. For what I'm talking about, the compliance, you don't need administrative right to support the compliance. Me like this, I don't have a specific user in any hospitals. You know, they have not given it to the region.
Yeah.
All that, when I go, I'll just, any of the terminals that have been hooked onto the LIMS, when you see that they have reports, I just go and run the report. The module is there, it's available to almost all those are the records. You can use any of their accounts and run. And when I run, I just see, and I'll go to one of the this and I just tell them, oh, maybe you see this one, when I check this, what happened, but you are not seeing this ABCD. You don't need, for that aspect I'm talking of, you may need other level access. I know you need access to some report. That one, you have to solve it internally. So we can look at it. But the compliance level, you don't need much access to do it. As far as you can view reports, you can go and check and see it. So we can look at it in detail for the detailed report, but not compliance. It's easier.
Thank you. Thank you very much. Philip, kindly be brief.
Okay. Thank you, GHIMA executive. I think I'm very pleased with this particular content of our training. I want to make a request that as part of our work, when we get to serve as health information managers, the primary part of our work is GIMS. But you go through a 4-year training or a 3-year training that you don't get any exposure to the system. So I want to request the team that is supposed to make inputs to the training of health information manager, if they can make it a course that can run from level 100 to level 400, I think it will help the system. So that's my request. Thank you.
Thank you. Thank you very much. Let's come to Enoch.
Thank you very much, sir. Just a quick one on your advice to those of us or those who have who are working and do not have the pins, the requisite or the requirement to. I just want to ask or put this across. We know that there are some training institutions in the country who train some of these professionals, being it health information officers, informatics. They come out well trained, but some of these programs are not Allied Health accredited. And for that matter, they don't have the opportunity to take part in the Allied Health exams for them to obtain the PIN. I just want to know or ask, is there any means that even if anyone happens to go through some of these training institutions and has come out, and some who have even been given opportunities or given appointments to work in some of our facilities and even districts, is there any means that as individual the person can be able to have access to write the exams, given the opportunity to register and write the exams to obtain the PIN, so the person become a qualified practitioner? I just want to know. Thank you very much.
Okay, thank you very much. And let's take the last one from Charles.
Okay, thank you very much. So mine is more of a suggestion, or let me say a recommendation. So with the LIMS, we know the challenges that we face with regards to data quality issues, whereby the reports that are generated within the LIMS are inaccurate. So we have to end up downloading the individual registers and then analyzing them so that we generate reports for the for management. So with the data quality issues involved with the reports, I think it's about time we, as an association, we generate these reports across the country, facility by facility across the country, and then submit the report to whichever authority that we deem appropriate for them to address the issues. Then when it comes to, let's take an example, consulting room, the interface, the various fields that need to be made mandatory. Example, provisional diagnosis. I know that all of us in the facilities, we have issues with this, whereby our doctors fail to enter provisional diagnosis in them. However, we know that this is a mandatory field. So we need to come out with a concise report or standard operating procedures for it to be implemented across the nation. That, oh, so for consulting room register, ensure that the provisional diagnosis is a mandatory field and it cuts across. We have that standard. Oh, for the admission and discharge register, or when doing the interface, admission and discharge, you can't discharge a patient without the final diagnosis being entered, so that it is a standard that cuts across the system, the LIM system nationwide. So these are my recommendation, that we sit as an association, come out with these documents, ensuring that health formation officers have access to quality data. Thank you.
Okay, thank you. Thank you very much. Senior Boy, do you have any comments on any of the issues raised before I come to leadership? Senior Boy, we can't hear you. Okay, so I think there was one that was talking about still on the allied health pin. You know, the council has a number of professions that they regulate. And because of that, they have a mandate of certifying institutions to provide such training to people, so such as health information. And before the council came into being, we are all aware that, we have people working in the health information profession from different backgrounds. And so there was a decision that before the council came into being and the law was promulgated and the implementation started, I think before 2014, all people who were already practicing in the service will be given the opportunity to obtain their licenses free of charge. And so you realize that all those who were already in the service before that particular period, we didn't write any exams. All that we did was to undergo the registration, and then we got our licenses. Post from that period, the services, by service, I mean the agencies, they are supposed to ensure that they work in tandem with the council. And so if the council did not accredit a particular facility to run a particular course, and somebody goes to do that course and come out, it will be very difficult for the council to license such professionals to work as health information professionals. Limiting that to health promotion, health information, because that is our profession. And so as it stands now, among all the professions that allied health regulates, it does not include public health. So if you go to Legon or UHAS and you do public health, though you specialize in information, but the certificate you hold is public health, and there is no any profession called public health. So how will the allied health license you to work? To work as a what? So you see the challenges that the council also have. And so that is why, as a health information practitioner, if you are going to school, you need to know the institutions and the courses that have been accredited or licensed by the council to run, so that you don't fall into this trap of going to do a particular program and coming out and you have challenges in getting the council to license you to practice. And so this is very, very important. And if you want to know or have this information, you can always go to the council's website, and then you'll get all information about programs and schools or institutions that have been accredited to run such programs or courses. We as an association, will continue to work in collaboration with the council to, ensure that members who are still health information practitioners and they have issues with PINs, they give some moratorium to see how those people can get licenses. And yesterday, this was well explained by General Secretary, and I think President also added his voice on that. And we even told you that the council have indicated that they will make a number of proposals before their governing body. And when they get the approval, they will let us know. So as and when such information gets to us, we'll also relay it to you, so that people who are practicing without PINs can have opportunity to get their license if they are qualified per the council's guidelines. So this is what I have to say regarding the issue about licensing. But my colleagues can add on if there is something that has been left out. Presido and General.
Yeah, all I would say is that we should just try and cooperate with the council, the regulator. You know, the regulator is just there for us. And we benefit, the professionals benefit from the regulation. So we should just try and cooperate by making sure we pursue courses in accredited institutions. Before you apply to an institution, find out if this institution is accredited by Allied Health Professions Council before you go. That will also help you, the professional, when you come out, and it will also help the council also. Thank you. That's all I want to add.
Thank you. Thank you very much. Those raising issues about, our colleagues who are sitting at home without, being employed. I think yesterday, General Secretary was emphatic that as part of our contribution to our colleagues who are sitting at home and unemployed, we are allowing them to participate in these CPD programs free of charge, so that will take off some financial burden on them instead of paying to get CPD points for renewal. I think he was very clear on that. And he even did indicated that anyone who have already done payment should contact us. And so kindly take a cue from that. So on this note, I will, Senior Boy, I was calling you if you have some comments to make, concerning the discussions that ensued.
Oh, I think it has gone on well, and all the comments have been taken in good faith. Some are suggestions, some we try to provide our responses. I'm sure those that the executive will work on, they will work on that. Those that I will also carry forward to my colleagues, RHIOs. We also have a platform we discuss issues. And after that, we come back to the executives for us to look at it, especially the LIMS issues.
Yeah.
Thank you very much. Anyways.
Thank you. Thank you very much. General Secretary, do you have any comments or announcements to make before I finally go to the President for closure?
Okay, thank you very much. I think you responded to the issue or the concern by the member regarding unaccredited programs. That was good. The other angle I want to come in from is those who have already done the program. What is the way forward for them? Which is that we put same issue before the council through the registrar in about two series of meetings we have with him. So he advised, pending the decision by the board that he was going to consult, we should put together a proposal for a short course with any of the university or training institution so that they can accredit that short program for such people. For instance, if you have a BSc already and you have to go do BSc to be satisfied so that you can, to be certified so that you can write the licensure exam, it's going to be a short program, not the 4 years or 3 years or 2 years. So we are looking at that, and we'll get back to members as far as the outcomes with the council is concerned. I want to also appreciate the presenter. Other members have done that, but I want to add my voice to that. And Sinoboy, be ready for part 2 of this program. I'm personally looking at some areas that we have to call on you again for part 2 so that we can benefit so much from this knowledge and experience. For instance, the issue regarding building a validation rule in Excel and all that, how we can go about it practically step by step. I think it's also a good get practical skill in that. Then I want to find out, Senior Boy, can you help reach the top regarding the mandatory field? Somebody mentioned it, but once it's mandatory field, it should be made mandatory. If the doctor doesn't feel it, he cannot conclude or his assignment. For instance, some of the field that they leave, though it is mandatory, but the system allows them to go on without feeling them. Is it possible you can use your good office, your connection to let the top know, so to restructure and make it properly mandatory? So this is a request I have for you. So thank you very much, my colleagues and Mr. Sino Boy and other members on the call. Thank you.
Thank you. Thank you very much. Mr. Boy, do you want to comment?
No comment. I think when the president, the general second, the president speak, we can't talk again.
He made a request to you and was asking whether you could. So.
Oh, okay. That one, yeah. It has already been tabled, and we only need to do a follow-up.
Very well. Very well. Thank you. Thank you very much. Those of you still raising your hands, unfortunately, because of time, we are unable to pick more, more questions or suggestions. But, the system is on. Anytime you join the link, you can always put up comments so that we can have access to it. And thank you very much, GFA, for making this this note that some people join and they keep rushing. We want registration link. We want registration link. Immediately the registration link was dropped, the number dropped from 320 to 210. So some people are just interested to just register their names and then they go off. It's not good for us as an association or as professionals, because we are here. Even if you know, there is nothing wrong in reminding yourself about the things that you need to do to improve the work that you do at your place. So this is just an advice or caution. On this note,
on that note, Senior, sorry, let me add this one to this particular one. Some of the executives, governors and other regional executives, they intend putting the link on their regional pages. Please, I don't think that's a good way to go, because if you do so, those who don't participate will have the opportunity to fill the form as if they participate in the program. So don't escalate it to your regional pages. It should be limited to those who practically participate in the program. Thank you very much.
Yes, and because we are getting AI to transcribe, it's very easy to track all this. So even if you give it to somebody to fill it, we'll track that out. Thank you very much. On this note, I call on Mr. President to give us his concluding remarks or closing remarks for today and the entire CPD program, because we are bringing it to an end. Honorable President, kindly unmute and proceed and address your people.
Yes, thank you, super moderator. And then good evening once again to cherished members. I just want to add my voice to the General Secretary's call for I don't know how to even put it, requesting from Mr. Boy to see if he can add his voice at the top for the mandatory field. Yes, I think with regards to the links, there is nothing that can be done for all the facilities at the same time. I mean, on one platform, because every facility has its own database. That is what I know. And so I think I also want to encourage health information unit heads in the various facilities to encourage leadership. I mean, they should call on leadership, data validation time, any forum that they happen to attend. They can still continue to call for medical officers' ability or making sure completeness of data capture is done during service delivery. That is what I want to add my voice to. And then I also want to inform cherished members that we are heading towards a page that kind of lukewarm attitude towards professional issues will not be tolerated as it used to. So when we don't come out to participate in professional programs to enable us acquire the necessary status, validity status, or whatever, we will put ourselves and the group, professional groups, into a tight corner that will not be well with the group and the profession itself. We need to uphold the integrity of the profession, the professionalism of health information management to be our priority. That is when we can also speak for what is due us. That is when we can also bargain for what is due us. So let us endeavor, let us try as much as possible to respond positively to the call of the association or professional group when it is time for such professional programs. This is a professional program, and like I said, for me, it is very dear to me because when we go to the offices, when questions are asked about what do we have as professionals to conduct what we are asking for, some of the answers and responses to those requests will be very, very difficult for leadership. Leadership is doing everything to improve on the integrity of this profession. And so we should also support. It is very, very, very important and very key. Then I also want to add from where General Secretary requested again that Mr. Boy should be ready for session 2 of this training. I also want to say that it will not be session 2, but we are going up to session 20. My reason is that most of the things Mr. Boy presented on has practical components. And so we need to find time and start doing these practical sessions, having practical sessions gradually. We must begin from somewhere. So, Mr. Boy, how do we conduct validation? You mentioned a lot of processes in one term, technical term. An example is the validation. What do you mean by validation? General Secretary requested for what? I think a validation rule or so in Excel. How do we go about it? You mentioned it, and that's why he's asking you that get ready for that. You have spoken big English. I don't know whether you schooled outside, have information in Ghana, and you are talking English from UK and Britain and America and so forth. No, bring us to the Ghanaian culture, society, Ghanaian practice. So you will demonstrate to us what you mean by validation rule in Excel, what you mean by data validation, and all the big jargons you bombarded us with. So I am appealing to the Education and Accreditation Committee and the Membership Development Committee to listen to the core of members that training, supportive supervision, coaching, monitoring, these are all big English that require processes. What are the processes there? Can we look at them gradually? So, Mr. Boy, we'll be calling on you. You can get a team ready. I am expecting number of such sessions, practical sessions, and it will be virtual. We can't meet as a country anywhere. Anyhow, we will plan it. Let's start putting heads together and see how we can roll out these practical sessions on a virtual level so that we start from somewhere gradually and see how it will end up. I will be very happy if this is brought into action. On this note, I want to just appreciate all those who were on call for this program. Yes, as we are closing, we have only 190, 191. That's the number I can see. We drop from 300 plus to 190 plus. And I think these are some of the challenges some of us have, but gradually let's see what we can do about that. So, Organizing Secretary, I appreciate all protocols that were put together to make this program a successful one. Thank you, everyone. Over.
Thank you. Thank you very much, Mr. President, for those insightful comments you made. So on behalf of leadership and organizers, I want to personally thank our distinguished facilitators. On the first day, we had Mr. Ivan, and today we had Mr. Boy for their insightful presentations and dedication to serving our association, GHIMA. To my esteemed colleagues and participants, I want to sincerely thank you all for your active engagement and for making this training a successful one. As we return to our respective roles, let us remember that the true value of this training actually lies in how we apply the knowledge to improve health information and strengthen our systems for better outcomes. We all engage you again. As the days go by, we will engage you again as we prepare the output of this training for submission to the Allied Health Professions Council. There are some of you that I sent private messages on the Zoom app, so kindly check your messages to reach out for some discussions. So I want to thank you all and wishing you a pleasant weekend. God willing, if there are any updates, we'll let you know. Those of you who are not part of the national WhatsApp platform, kindly contact your regional executives and they will reach out to the administrators of the platform to add you, because every communication, that is where we send it to. So thank you very much once again and have a pleasant evening. Goodbye to everyone.
Bye. Thank you.
Bye.
Thank you too. Goodbye, everyone.
Thank you. Thank you, Sandra.
Thank you, Honorable Moderator. Bless you.
Thanks very much.
As everybody is saying goodbye, let me also say some goodbye.
Goodbye. Good hearing your voice.
Goodbye.
Goodbye.
Bye.
Goodbye. Goodbye. Goodbye to everyone.
Goodbye.
Nyakpa.
Goodbye.
So
Anas,
this goodbye,
Anas.
can we say it in a Ghanaian, any Ghanaian language?
Oh, no, that one is not important. They made me remember I went to a classroom, KG classroom. Once I was leaving, one of them said goodbye. Everybody wanted to say so.
Oh.
So I just remember. So I'm enjoying hearing the goodbye, especially
goodbye.
the different tones and all that.
The different tones, yeah.
Goodbye.
Goodbye. Bye bye.
I feel like saying some more. Goodbye.
Bye.
Bye,
Goodbye.
Adiapa.
Let me also say some more. Goodbye.
Florence, goodbye. Thank you. Thank you for joining.
You're welcome, sir.
Goodbye.
Cecilia Nyako, we haven't heard your voice, so we haven't heard your goodbye. Jennifer, we didn't hear your goodbye too.
Goodbye.
Goodbye. Safia, we didn't hear your voice, so. Obake.
Goodbye.
Yes, so Derry Ebenezer, I think I sent you a private message to reach out. So kindly reach out. Derry Ebenezer.
Thank you. God bless you.
Thank you, Grace Nate. Take care.
Thank you. Bye.
Bye. Bye.